So my name's Jeremy Simon. I was at Rothman for a pretty long time. I was for about 18 years. I took a brief hiatus and then came back and sort of a little bit of a different role. So I'm going to share with you guys my screen now. Natalie was helping me with this earlier, so let me make sure I do this seamlessly. Okay. So the title of this is EMGs. Are they really that EMG nerve conduction studies? When do I need one, and are they really that awful?
Dr. Simon, sorry to interrupt you. I don't see your screen yet.
Oh, sorry, my fault.
It's
Say you
okay.
showed me, and now I'm sharing it. I'm
There
so
we go.
thank you, thank you
Yeah.
for doing that. There may be actually some people who I've actually seen before as patients on here too. But one of the things I'm not great with is technology. So I appreciate that, Natalie. So these are today's topics. So I always think it's interesting to talk about the history, like how did we sort of come to be able to do EMGs, and also it's kind of interesting to see what they used to look like compared to what they look like now, sort of the progress. So we're going to talk about what they are, EMGs, what are we helping to diagnose and how, and certainly why would anybody order this test or why should you get it? What I really want to talk about too is what you can expect. What does it feel like? I'm going to show you a video that's available on our website as well that I recorded with one of my friends and co-physicians at Rothman. Of course, what are the risks? And then, as Natalie said, if there's some questions, and what I'll tell you is, we're gonna try and answer as many questions we have that we can in the time allotted. So I wanted to start with just sort of a little bit about me. So I'm a Philly born and raised. I grew up in Northeast Philadelphia. I went to Jefferson for medical school, Jefferson for residency. I did a fellowship in interventional procedures, which I'd done for a very long time. And then, I've kind of circled back to what's been my passion, which is really I like to spend time with patients, and I get with EMGs, I get the time to really talk to people. I get about 45 minutes per session. I pride myself in being a good clinician and diagnostician, so it gives me the time to really use my brain, spend time with people, and focus on the clinical problem that's being sent to me. I also enjoy teaching. So I have a faculty position at Jefferson. I get to work with residents and medical students. Sometimes they'll be in the room with me when I'm doing that, and it's exciting to be able to incorporate the things that I'm doing in the test to their learning. So as far as the history goes, the first time that sort of it was noted that muscle tissue was responsive to electrical activity was in 1771, actually. Luigi Galvani discovered that if he stimulated some muscle tissue, it actually made it contract. So that was sort of the first time that it was noticed that there may be some electrical circuitry in the muscles. Fast forward to 1890. Etienne Jules Marie introduced the term electromyography, and he actually was able to show that there was bioelectrical activity in the muscles. In 1922, two physicians, Gasser and Erlanger, began trying to actually record the nerve impulses. And if you've ever seen the old sci-fi movies, I have a picture of this a little later, but they had what's called a cathode ray oscilloscope. It's when you have this kind of wavy thing going across the screen, and later it was used in EMGs. 1929, Adrian devised a method where you could actually hear what are called motor unit potential. So that's when you move a muscle, it's the electrical activity that the muscle is making by connecting what's called a concentric needle. It has recording equipment in the needle and an amplifier, so you actually hear the sounds of the electrical activity within the muscle. The first modern EMG machine was constructed at actually McGill University in Canada. And then in 1950, the first commercial ones were available. So this is a picture of what the old machines used to look like. And that on the screen here, if you see this thing, if you could see my arrow, this was the oscilloscope. And you could see this was what actually generated the electrical activity. It's kind of intimidating, and this is how you would record it. The recording of this, it actually took a lot longer because you'd have to print the like on a piece of long strings of paper. We had one of these when I was a resident in the Jefferson call room, and it was, kind of intimidating looking. This is more of a modern, this is a modern EMG machine, sort of an example. You can see it's much smaller, a lot less intimidating. I like that this is from the doctor's toy store, but this is similar to the ones that we use in most of our offices. And you can see obviously that it's on a computer screen that captures the image. It's all digitalized. The ways to get rid of any background noise, like the crispness and clarity of what we see, allows us to do it sort of much faster and not require nearly as many stimulations, which we'll get to later, than they used to. So what are EMGs? So, we use the term EMG. It's typically involves two parts. The EMG is actually one part of the test. It's short for electromyography. So what they are in general is a test to look at the function most commonly of individual nerves, or a nerve or nerves in the body. It typically takes about 30 to 45 minutes. Now that's not in constantly doing anything to a patient. Like we have to, you know, uh, bring you in, kind of review your story, examine you, explain the test. Even though you get a consent form, or it may have been explained briefly. You may have looked on YouTube or Google or things to look at it before, but I always make sure that we explain what's going to be involved. And then it typically, in most cases, has two parts. So there's a part called the nerve conduction study, and a part which is the involves a small sort of pin needle electrode, that's the EMG, but it's often abbreviated EMG, and many of the referring doctors will say, "I'm sending you for an EMG." So the nerve conduction studies are actually done most of the time before the EMG part. So what that involves is using a very small electric current to stimulate a nerve. So the nerves are like electrical wires. It's kind of interesting that when your brain sends a signal to move a muscle, there's an electrical impulse that starts in the brain, comes down through the spinal cord, and then comes out nerve roots if it's an arm or hand, it comes out through the neck. It goes into what's called the plexus, which I'll show you a picture of later, and then eventually down through the nerve that connects to that specific muscle. And then if you touch something, there's an electrical impulse that's generated, in your hand, that goes up the other way to your brain where it's interpreted. So what we can do is we can give a small electrical current outside the body over top of that specific nerve, record the signal, which will come up on that computer screen, and then we can interpret some things to tell the sort of the how that nerve is doing. So we could see if the size of it's too small, or if it's going too slowly. Even kind of more sophisticated, sometimes if you're looking in an area where it could be compressed, you can see it kind of the amplitude, the height of the response kind of gets smaller when you're getting above where the compression is. And then we look at different types of nerves. So there's what are called motor nerves. So the motor nerves are the ones that go to the muscle, and then the sensory nerves are the ones that are involved in feeling. And teasing out which abnormalities, which nerves are affected, where, can help us not only tell where the nerve is affected, but also how bad it is, how badly it's affected. This is an example of a setup for a nerve conduction study. So this here is called the stimulator. So you give a small electric impulse. In this case, it's over the nerve that goes through the carpal tunnel, which is in this area. Carpal tunnel syndrome is a very common reason we get referrals for this test. And then these are recording electrodes. So sometimes people look at these. I've had people say, it looks like something I would hook up to my car battery. But this actually all this does is record around your skin, where the nerve, in this case, the nerve through the carpal tunnel called the median nerve, where that goes. So it's just recording equipment. This is what generates the small electrical impulse. This is an example of what we may see on the screen. So if you look here, let me go back. Sorry about that. The these are called waveforms. Okay. In the top here, this is an example of one that's going a nerve going through the carpal tunnel, and you're recording at different places. So here, I would give that shock down at the wrist, and then we follow the nerve up higher to where it comes through in the elbow area, and then you can see that they're sort of different places, and you're recording down at the hand, so this different periods of time it takes to get there, and then we measure it, and you can tell the difference in the time. This gets into the weeds a little bit, but distance divided by that time, you can calculate what's called the conduction velocity. So, like if you're driving your car 50 miles per hour, that's the velocity that it's going at. So we can tell if it's going too slow between those 2 points. That can mean that there's a problem with the nerve, in terms of how fast it's going between those 2 points as well. Um, so what does it feel like? So it does not feel like what we see on the other side. So like an electric chair. Some of the shocks can be stronger or smaller. None of them are like sticking your finger in a socket or getting tased. A lot of people will ask that. If you said, what does it feel like? It kind of feels almost like the sensation of a static shock. So if you walk across the carpet and touch a doorknob, you're wearing flannel pajamas or something and touch a TV, it's not a pleasant feeling, but it's not a terrible feeling. Some of the ones that can make your muscles move for a split second, which is interesting. I always hold the patient's hand, or if it's in the leg, their foot, so they don't feel like it's moving. But it's too much. But they make a move for a split second. So that a lot of times people kind of laugh when I'm doing it because it's not a voluntary thing that you're not used to. But it's what most of the time happens is, and I always tell this to patients, and oftentimes I'll show them on me if they're nervous before the test. I'll say, here, watch my hand here, and you can see it move. It's usually the first time people feel something. If they come into it, especially with anxiety, they'll go, ooh, and then they kind of know what to expect, and they go, oh, okay, now I know what to expect. Not nearly as bad for most people as what they anticipate. Um, the EMG part, or electromyography part, we use a very small, thin needle. It's an electrode. And what this actually does, it's quite interesting. It looks, and you're looking because you get readouts on the screen that correspond to different things, parameters that we use to diagnose problems. And you also hear things. There's a shape, sound of the individual, what are called motor units. That's the act when you activate the muscle, they're called motor units. We also have you keep the muscle first at rest, and when a muscle is at rest, it should have a characteristic things that you see or don't see. So the sounds and shapes that we hear and see on the screen help us diagnose problems with the nerve that goes to that muscle. So sometimes that can help us diagnose pinched nerves in the neck or back because there's muscles that have certain nerve roots from the spine that go to them, and other ones that don't have those roots should be normal. Or nerves that are damaged in the arm or hand. You can see ones that are specific to those, the muscles that are supplied by those nerves. And then again, the way that we do it, we have you keep the muscle kind of limp. I always say limp because if you want someone to relax, you don't tell them to relax. That'll make you not relax. But then we say gently contract, so you don't have to push real hard or anything. And we listen and look at that activity. What does it feel like? So I always tell people too, I'm a teacher, and one of the things we do in medicine to pay it forward is we always when possible, I let medical students or residents try to do the test on me so that they can I can give them feedback before they would be doing them on patients. And I was always appreciative that first time I drew blood was on one of the interns when I was a medical student. The first time I placed an IV, a very nice nurse let me do it when I was on my OB/GYN rotation. So I always feel like, helping the doctors, sort of giving them feedback on that. And also I know exactly what it feels like. So what does it feel like? Well, for the needle part, it feels like a quick pinch. For people, sometimes we'll use cold spray, or if they request it, sometimes people don't like that feeling. So, but it's quite small and thin. It's not like getting a shot. Sometimes when the needle's there, it could be aching. Usually, for most of the time, if we're doing a single, arm or leg, it's usually a total of about five muscles, sometimes six muscles. Anytime you get a needle, you can get a drop of blood or a bruise. Some muscles could be more or less sensitive. I always assume that nobody likes any of these feelings. So I always try to be kind, and even people who are stoic, I'm still very gentle with them. And again, some people are more or less sensitive. One of the things that's interesting to me, even in my practice where I was treating a lot of back and neck problems, is there are some people that have different levels of tolerance. You'll sometimes see people that have very large disc herniations and are not bothered by it too much, and some people that have smaller disc herniations that for whatever reason it's very, very painful. And there's some people that come in that are very stoic. My grandfather was a World War II vet. He used to dump alcohol on all my cuts, and his cuts, and he'd say pain is like an old friend. I don't assume that the average person was like my grandfather. I don't want people to be uncomfortable with this. And there are tricks that I use. There's tricks that I use when I give injections in the past, and tricks that I use for this to try and make it more comfortable. I always am constantly asking people how they're doing. I want their feedback. And I teach that, when I have residents and medical students, which, by the way, if anybody is in there, when that were to happen, they never have to do that. Like they're there to learn, but it's your body. So if someone said, I don't want a resident doing it, there's no offense or anything like that. This is a typical needle EMG. I couldn't get you. This is a very small needle. This is 27 gauge. And it's hooked up to a wire, and that wire is hooked up to our machine so that we can interpret the findings. This is an example of kind of what we see. So on the left side over here, this is when the muscle's at rest. This is an example of some abnormal things that we can see. So these are called positive sharp waves, and this is called a fibrillation. In a normal situation, it would be kind of flat across the screen. These also sound kind of like rain on a tin roof. These are when the muscle's at rest. If someone has nerve damage, one of the things that the nerve does is keep the muscle quiet. So these are it can what's called destabilizing. These things fire off spontaneously. So just kind of on their own, they can come out and do that. This is on the right. I have this kind of marked here, but these are different motor units. That stands for motor unit action potential. So these are three different motor units that we see and when someone's activating the muscle that are firing normally. That's what the sort of the active thing that we have you do. So what are we helping to diagnose? So I put these complicated pictures because sometimes it can be complicated to see exactly the extent of of what nerves can be affected. So you can look many times at problems from nerves being affected in the spine. This area here is called the brachial plexus. So after the nerves come out of the neck, this is where the root is. Up in here is the neck, or in here in the low back is the nerve root. When someone has heard the term radiculopathy, if anybody's had that, radicula means small root in Latin, and then apathy is a problem of or disease of a different, and so if you have radiculopathy, that means sort of the medical term for a pinched nerve and if it's cervical, it's the neck. If it's lumbar, it's in the low back. So we can help if there's nerve damage or suggestion of radiculopathy in the neck or back. I look at this as kind of the circuit breaker, and then as the wires come out of the circuit breaker, this area here is called the plexus. Called the brachial plexus in the neck upper extremity. This is the lumbosacral plexus in the lower extremities. And then the nerves kind of branch out and go to different destinations, in the from the neck down into the arms and hands, and then into from the low back into the legs and feet. So we can look for pinched nerves in the arms or legs, things like carpal tunnel syndrome, pinched nerve in the elbow. In the leg, there's sometimes you can get pinched nerves around in the lower part of the leg. something called a fibular neuropathy or perineal neuropathy. There are certain nerve diseases. Some of you may have heard the term neuropathy. So neuropathy, again, apathy would be disease of or problem of. There are some people that have something called peripheral, meaning out in the arms and legs, hands. Peripheral poly, meaning many neuropathy. So the most common cause in the United States is diabetes. So diabetic patients, from having high sugars over time, can have problems where it can cause nerve damage, and it can affect usually the feet first. They can get numbness, tingling, burning in the feet. And then it can, if it's really goes on for a long time, it kind of can go up the legs and involve the hands and arms. So it's a test that in many times, sometimes if it's too mild, we won't pick up, and we don't pick up everything on this test. But it's one of those things I've kind of indirectly diagnosed people with diabetes. Sometimes people hadn't been to the doctor in a long time, and they came in, and I said, I see this pattern in diabetes, and then they, end up having that. There's other things that can sometimes creep in that can mimic other problems that we end up picking up, and then certain muscle diseases. So there's some muscle diseases that are autoimmune, meaning your body sort of attacks the muscles, and they sometimes come through into my office as well. So how does an EMG help the diagnosis? Well, what we do when you come in is I always review what the referring doctor, whether it's a hand surgeon or one of the sports doctors or even your family doctors, which we take them from family doctors. I have referrals from rheumatologists, doctors that treat autoimmune diseases. I look at what they're looking for and what the question is. So I always want to see why you're being sent from, in terms of their question. And then any relevant imaging. So sometimes a doctor will order an MRI of their neck or back, and they order that, and then the EMG because maybe they were confused because there was a few different things going on in there, or other important studies if the blood work was in question. Um, I always take a history. We learn in medical school the most important thing when a patient comes in is get their story. We want to see what is it that you're feeling. Why did you go to the doctor? Why are you getting this test? Why was it recommended to you? What are the symptoms? And then always examine you. I have picked up things, in my um, when I'm examining people that may not have been obvious at the time because of the timing. When they saw the doctor, and then they came to me. Um, the nerve conduction studies. So we plan it out based on what the doctor's looking for, what your story tells me, and what your physical exam tells me. So we don't do the whole body, only very rarely. So we pick out which nerves, and often there's one you want to compare what's affected to one that's not affected, or sometimes one side to another side, depending on the symptoms. Or sometimes you do it on both sides if the symptoms are on both sides. For that's the nerve conductions. And then for the needle part, again, I don't do your whole body. There are times where, for either because a patient is not doesn't need it, where I don't have to do the needle study, or you only do a couple of them. And then there's times where you have to do more, depending on what the presentation is, than maybe even what was ordered. But that's we target it based on what we think is going on with the patient. And then at the end, you put it all together with the history, the physical, the imaging, as well as the study to give a diagnosis. I always let the patients know, if you come to see me, what my diagnosis is. It's not like when you get an ultrasound or an MRI because a tech is doing it. So I always tell you, I found that you have carpal tunnel, and we grade it mild, moderate, or severe. Your case was moderate in the right hand. I did not find these things, and I always give you a copy of it so you have it for your records. I think it's good to have it, in case any other doctors need to see it. Plus, you can file it away. It's also available on our portal and can also be reprinted for you when you follow up, if you follow up with one of our doctors or if you request it. So how does it help again? So the symptoms, a lot of times, people can come in with symptoms that are very straightforward and you don't need an EMG. But sometimes it can be confusing for the patient and the doctor. So a lot of times people say, well, where are you numb? Well, a lot of times when people have carpal tunnel, they don't sit there thinking, am I numb in my median nerve distribution? They may think it's like the whole hand, it's the whole hand. And it may not be obvious when the doctor examines you. Some of the things we do can be a little bit, tough to tease out. You touch the hand different places, you try different maneuvers. It may sometimes be in your neck and shoulder and in your hand. The imaging may not be exactly clear. So it can help it sort of tease that out, like what comes up normal, what comes up abnormal. And then also when the doctor gets that, your treating doctor, they look at the EMG and they may say, well, this was actually worse than I thought. We may actually be leaning more towards surgery, or, it's maybe better than I thought. Maybe we can kind of go more towards the conservative stuff. And again, they can, as I mentioned, can frequently help you diagnosed in terms of the location so that they can do sort of a more specific, you can be more specific in terms of what your treatment may be and also severity. So some of the parts to use carpal tunnel as an example, one of the uses of it is typically on how, quote, severe is it. So we can tell if it's carpal tunnel syndrome. Typically what it'll do is it'll affect the sensory nerves, the ones that cause the numbness and tingling first. Then over time, it can start to get the motor nerves, the ones that are involved in strength that go to the muscle in the hand. And then if it's sitting there for a long time or severe enough, then you can also start to get nerve damage, which we can see on the needle part. The risks of this are actually very minimum. So you can stay on blood thinners for most studies. Really, I couldn't tell you a study that I've had to do recently where someone would actually have to come off of a blood thinner. The infection risk with this is extremely low. So I obviously clean you off with alcohol, but we're not. It's not if someone had a knee replacement or a hip replacement or other joint replacement, you don't have to get pre-medicated with antibiotics. I've had that question before. If you go to the dentist or get a colonoscopy, they often make you do that. Obviously, you can get a bruise. We're not near any major blood vessels for the large majority of these. So any kind of major bleed would be very, very difficult to cause. People who have, like if they have a pacemaker and defibrillator, some of the studies, most of them are safe. There are very few, and if there was a question, we always tell people to call, ask their cardiologist, but before coming to it. But most of the studies, especially the ones in the legs and feet, and even the ones in the hands, often can be done safely. But we always tell you if it's in an upper extremity one, like in your hands, we always just make sure it's okay with the cardiologist. We wouldn't want to take any risks, obviously, with you. The needle part is safe for any of it because there's no shocks that are given with the needle part. But you often need, most of the time, you need both the needle and the little electric shocks. Rare complications. So I put consent form here. The consent forms in the area are always scary sounding. They have on there a punctured lung. There's a very specific test that we have to do for a very specific problem that's the only time that comes up. So it's if someone has something called scapular winging, where the scapula kind of juts out from a nerve injury to the muscles that go there. That's the only time we're ever around that area. Passing out, like, so anytime, I had a patient one time that came in, and the first thing he said to me was, it was a big guy, about 350 pounds, and very strong construction work guy. He just said, hi. I said, hi, I'm Dr. Simon. Nice to meet you. He said, I just want to let you know I don't like doctors. I said, okay, okay. And he said, do you mind just showing me my pictures first? I said, okay. So I'll show that to you. And so I showed him a picture and he passed out. So some people pass out from talking about stuff or coming in, or sometimes they pass out and it's not under voluntary control. I always ask people constantly, are you doing okay? Are you doing okay? Just to make sure they're not a person that happens with. But that's more of a anxiety thing and sort of specific to individuals. Um, I have a video I want to show you guys that I made. I referenced it earlier. I made this video with one of my colleagues, Dr. Garrett. Maybe one of you have seen, he's a friend and colleague, but this is a video that's available on the website and just kind of has me walking you through it. And then It just takes just a brief minute. I'll be quiet.
Your Rothman doctor has ordered an EMG and nerve conduction study to aid in your diagnosis. The following video will help you prepare for your test. This test will be performed by a Rothman physician and is composed of two parts, the nerve conduction study and the EMG, also known as electromyogram. The nerve conduction study consists of delivering a series of small electrical currents or static shocks to the limb being examined. The EMG consists of inserting a very small, sterile needle into one or several muscles in the limb being examined. Once inserted, the needle will stay in place for approximately 30 seconds. The needle itself is an electrode and will record the electrical activity from inside the muscle. Most patients describe the EMG and nerve conduction study as uncomfortable but tolerable. However, pain tolerance varies from patient to patient. Keep in mind that you can ask for the test to be stopped or paused at any point if you find it too uncomfortable. Side effects of the test are minimal. Your doctor will discuss any potential side effects prior to testing. To prepare for your test, be sure not to wear any lotion, cream, or sunscreen on a limb being examined. Do not stop any prescribed medications prior to the test, including blood thinners. If you have any questions about your upcoming test, please contact your ordering physician through the patient portal at rothmanortho.com.
Okay, that was the small video. You can see Dr. Garrett is very funny and was making me laugh during it. Um, Anyway, so in summary, so the EMGs or EMG nerve conduction study, also known as electrodiagnostic studies, are safe, typically well tolerated. They're very helpful for diagnosing nerve problems. They're also helpful in seeing how bad a problem is. What you would expect is probably about 30 to 45 minutes for the study. You can expect to feel some small shocks and small needles into specific muscles. And I will be nice to you. I do not get any pleasure out of people being uncomfortable. I would make sure that I would want you treated the way that my family member, I would want them treated, and answer questions as best I can. So that being said, I'm going to ask some questions. There's a picture. My son just got into Purdue, so he's 18, and we were all wearing our Purdue swag. So thank you.
Dr. Simon. So we did have some questions come in. So I will ask them to you if that's okay
Yeah,
with you and you can answer.
absolutely.
All right, perfect. Okay. So the first question is, can injured nerves regenerate? If so, would you periodically repeat EMGs to monitor this?
So that's an excellent question. So I will say that one of the things that the EMG is useful for is seeing, quote, how bad it is. So there's some parameters that we look at and just to see what the likelihood of that is. So one of the things is you can tell when we do the conduction side to side, you can look at what's called the amplitude, which is the size of the response. So if you looked on, like, say my right, it was a nerve to my right hand, and the amplitude of that nerve was like 5, and I looked at the other side and it was 10. Then you say, well, there's a good chance it's about half of the size of the other one. That if that whatever is causing that, if it was something like carpal tunnel syndrome, if that was the pressure was taken off, that nerve can regenerate. We also get situations where someone has had a nerve injury, it has been kind of taken care of, and the symptoms are kind of lingering on. So one of the things the doctor will often do is, someone may have come to one of our spine surgeons, for example, and said, they dealing with this problem. Again, depends on kind of how long it's been going on. They can't take it anymore. They're having horrible sciatica pain. They have surgery, and the symptoms are kind of taking a while to really go away, or they're lingering around. So the spine surgeons often will order the test to see kind of the status of the nerve. So we look at it, we see how bad it is, like what we get, kind of the function of the nerve at that point. And then if it's been well taken care of, decompressed, as they say, a nerve typically will regenerate, and it can about an inch a month, or a millimeter a day. So depending on how far the nerve has to go from the site that it was injured, it can take a while. But the long answer to the short question is that yes, The nerve can regenerate. Un Unfortunately, never as fast as people usually want it to. It may not regenerate completely, but the EMG kind of helps in terms of telling you what the chances of that happening are in many cases.
Thank you. And kind of going off of that question, should repeat EMGs to monitor any nerve regeneration be done by the same technician and facility? So are the results consistent or repeatable across multiple testing sites?
That's a very good question. There is often what they call inter-rater differences, right? So there's sometimes where the equipment may be somewhat calibrated differently. There are times where um, the skill or the person doing it may be different. In general, it's not absolutely necessary to have to go to the same individual. Like, so if someone saw, Dr. Garrett, who was in that video, and then saw me, it should be okay if another study would be needed. They're not always indicated, repeated studies to track progress. A lot of it is driven by how you're feeling. So if one of the things that people are dealing with is weakness, when you go to see a doctor that ordered the test, you may go in and say you have something like, quote, a foot drop, where you literally can't lift your foot up like this. And then they order the test, and we see, yeah, you have, say 50% or half of the nerves compared to the other side have been damaged. And then they say, okay, well, this is what we're going to do about it or not, or we're going to monitor it and send you to physical therapy. If your symptoms are significantly improving, and they continue to be improving, you may elect to sort of wait and see how that's going. If it's kind of like a slow progress and it's been several months, then oftentimes, we may say, oh, well, it's worth repeating it. Or if it's a really dense lesion and you're kind of, they call static, meaning not getting better. Sometimes you can see improvement from the previous study that may not be presenting, that you may not be aware of, or we can't tell on a physical exam. So it's kind of one of those things that, when or if you do it, is a decision made uh, based on your symptoms, based on the problem often at hand. And then, but in terms of, is it an absolute necessity to go to the same doctor? No, you don't have to. I mean, ideally, it's better to have the same person who saw you the first time do it again, because it's the same equipment, same doctor. That that potential for a little bit of variation is accounted for, but it's not absolutely necessary.
Thank you. Next question. Can the test determine if leg tingling is the result of sciatica versus arthritis? Can the test determine if pain is the result of a disease like MS?
So great question. So the test, which I should clarify this, I kind of buzzed over it a little bit, is not a good test for MS or what was called central nervous system problems. So central nervous system would be brain and most spinal cord conditions. So we can't reliably study that. There are some other variations of this test that are done in some neurology labs, but they're even still, it's not like the be all end all for diagnosing it. It can aid in the diagnosis of sciatica. So what we always look at are, what are the patient's symptoms? Like, so if they have symptoms like pain or numbness that go down the leg, in most cases that could be kind of something that we could pick up on a history, the story you tell, and the physical examination. And then that can be confirmed with imaging studies, X-rays and or MRIs or CAT scans. Sometimes the symptoms, to answer that question, could be a little bit tough. Like, people say, well, I have back pain, and that could be from arthritis, and then my foot tingles. Are they connected? So many times, not every time, you can get some additional information from the EMG. If there's any sort of chronic nerve like being pushed on, you can sometimes find some things on the study that could tell you that it's more than just arthritis, that there's some compression of the nerve over time. So it can aid in that diagnosis.
Thank you. Next question. This person said they recently had an EMG due to sensations being felt in the toes of one foot. The test didn't show anything. Is there a follow-up exam that you recommend for this type of issue?
So, that's a tough question. So I would say it depends on kind of what they were, what the doctor was looking for. So, without, knowing the clinical history, what I would tell you is that, so like anything, the EMGs are not a perfect test. There are times where you can find things that are not relevant. So one of the examples I often tell patients is like if you went, God forbid, they suspect you have like pneumonia or something. So they give you a chest x-ray. So the chest x-ray looks at your lungs, but it also happens to catch your ribs and what's called your thoracic part of your spine, so the heart shadow. So they may say no pneumonia. There's some mild degenerative changes in your thoracic spine, but that's not why you were sent. You're not having symptoms from it. So sometimes you can find things on an EMG, like some mild slowing of the nerves that can happen with age or time, may be normal for you. And then there's times where you're looking for something, and depending on how bad the problem is, it may come back actually normal. So it can fall within normal limits. And there's other factors that can be taken in. Sometimes people have a lot of swelling in their foot, and it can be tough to interpret that. You can have some technical challenges with it. As far as follow-up, you really do have to talk to the referring doctor because it depends on what their diagnosis is. There's other things that can cause numbness that may not be picked up on an EMG. Sometimes it's not worrisome or it can be beyond the detection limits. Sometimes there are things if it's getting worse, like where they can, if you go to sometimes there's other studies that could be considered. There's biopsies of different nerves to look for something called small fiber neuropathy, which would not be picked up on an EMG. We look at bigger nerves. So the smaller nerves can't be studied on an EMG. There's some detection limits of what we can see. Sometimes there's blood work they can do. So I would say if it's bothering someone enough, they should kind of follow through with it. And the EMG wouldn't shut the door on other potential diagnosis.
Thank you. There's a couple of questions, so I'm just gonna kind of try to combine them. Um, Mentioning their A1C. So this person says the front top of their legs are increasingly becoming numb. The most recent A1C was a 5.5. The other person's was a 5.9. Is it safe or helpful to conduct an EMG in this case?
So I will say that it probably would be unlikely. Well, if it was higher than that, and again, one of the things is you may not know what it was before or what it is now. So it's definitely safe. If the question, which often comes up, is what's causing it, right? So there are times where if it's constant, it's more likely to show something, so that the something can be other things besides neuropathy. Usually, if it's neuropathy and neuropathy from diabetes specifically, it'll kind of feel like you're wearing a sock, like in terms of the numbness distribution, or it often starts, not always, but it often starts on the bottoms of the feet. The top of the foot can occasionally be from diabetic neuropathy. Usually, you'll see it in people who have A1Cs that are like kind of a lot higher than that. But you can sometimes see it in people whose nerves are more sensitive. You can also sometimes pick up some other conditions that sometimes it can be from the back, like you can get some symptoms in the top of the foot from the lower back nerves. L for lumbar is the lower back, like L5 can do the top of the foot. There's another nerve that comes around the leg called the peroneal or fibular nerve. There are neuropathies that can be affected there. One of the things that we do too is when someone comes in, because I see and my colleagues see nerve problems all the time from various conditions, is that we take a history and see if we may have a different perspective than whoever was treating you, and also examine you to see if, in addition to the test, to see if there's anything that jumps out at us as well. But it would definitely be safe, and if it's bothersome, appropriate to come in for a study.
Thank you. This next question, this person says they have back pain, lower back, upper right hip, and groin. Two questions. Do pinched nerves show on a lumbar MRI? And might an EMG be useful in this case?
It's a great question. So most pinched nerves do show up on MRIs. You take it into context with the type of symptoms that the person has. So those symptoms that this individual is having can be from pinched nerves. There are times where it can be from a hip too that can mimic that. And when I see people again, whether it was in the office or even when I'm doing the EMGs, I always examine them just to give you my 2 cents. I had someone that got sent to me the other day that they thought might have had a nerve problem because they weren't able to lift their like hike their hip up. But I could tell from even the physical exam that they had a tear in the muscle. So I ruled out that with the test as well, and then also suggested to their doctor and to the patient that they get an ultrasound. So one is we still examine you and still, and I would make suggestions if appropriate. And the other thing is, yeah, usually it shows up on an MRI if it's kind of not clear, then the EMG often, not always, because sometimes it can be more like inflammation of the nerve, which won't show up, or irritation. But if it's significantly compressed, if it's kind of causing kind of constant or very frequent symptoms, it often does show up on the test, and it would be appropriate.
Thank you. Can can a damaged motor nerve be repaired without surgery?
So yeah, so that kind of gets back to I guess the business of nerve regeneration. So this is an area of investigation because a lot of times that doesn't get repaired enough, or it doesn't. So. It depends on how bad. So the motor nerves are the ones that go to the muscles that can cause significant weakness if they're damaged. So in those cases where people have nerve damage, even even surgically. So when our surgeons, like say it was from if it was from a herniated disc, our spine surgeons would take the pressure off of that nerve. And then the hope is that it's going to regenerate now that the pressure's off the nerve. If someone had another kind of injury, I had an individual, young man actually recently, who had a dislocation in his shoulder, and it caused the nerve to get damaged. And there wasn't even a surgery if he wanted one to go at that nerve. They sometimes will go in, and if the surgeons can sometimes go in and sort of dissect around it to give it more space and put some things on there to do that. But the nerves can regenerate if they're not under constant um, compression, or it's not in certain disease entities. There's certain nerve diseases that can attack the nerves, or inherited ones, or there's one called Guillain-Barré syndrome, which is can happen after an illness, where their body gets confused and attacks the nerves instead of just the virus, or where once that's kind of cleared, depending on how bad the hit was, those nerves can regenerate without any other intervention. Medication wise, there's not really great medicines for it. There's some supplements and things that people sometimes will try if there are no reason not to. There's one called alpha lipoic acid, which I often recommend to patients that you can get over the counter unless there's someone who has an allergy or to it, that can sort of be like glucosamine is for the joints. It helps kind of give you the building blocks to do that. What we usually tell people when they have a nerve injury that's affected the motor nerve, it's very important in most cases to try and strengthen the muscle, and strengthen what you have, so that you're giving the nerve a target to go back to, and also make it stronger with the nerve function that you have. So it's a bit of a complicated answer for a complicated problem, that they can, but they don't always, and then often not completely.
Thank you.
Hmm.
Then there's another question. This person says they've had burning mouth syndrome for 7 years. if there is damage to my trigeminal nerve, I don't know if
Trigeminal
I'm saying
nerve.
trigeminal nerve, can the EMG test detect that? And is nerve block or nerve stimulation appropriate?
So that's that's a tough problem, obviously, to have. That study is typically done in specialized neurology offices. So it can be useful for the trigeminal neuralgia. There's a specific study called a blink study that's actually done in the face um, that can sometimes be used to sort of tease that out or see if there's a severity from a trigeminal neuralgia problem. Um, Stimulation is a complicated answer. That would depend on a lot of health issues people have, and there are some doctors that do I know that do what's called peripheral nerve stimulation. So in cases where in very specific cases where people are a candidate for it, they could either a doctor could either use what's called a stimulator, which sends an electric impulse over top of the nerve or an area that the nerve is being sent to basically block to get that signal ahead of the pain signal. Or in very select cases that people can have something called a rhizotomy where they cut the nerve, but that's very, very specific situation.
Thank you. Next, this question is about this is a person who received a cervical epidural steroid injection to address the C6 nerve, which they thought was causing the numbness and tingling in his thumb. And the symptoms have been going on for about 2 to 3 months. Um, in a case like this, or if somebody else had a similar case, they receive some relief from the steroid, but they're still experiencing constant tingling and numbness
Yeah.
to a lesser extent. Would they be a candidate for an EMG study?
That's an example of one that's often very appropriate because so the C6 nerve, when I teach med students and residents, the mnemonic that we use is like a six shooter. So it typically goes, to the thumb, and that's where the C6 nerve classically goes. But there are some other nerves, like there's a nerve the nerve further down through the carpal tunnel goes there. But so there are cases. I had a patient yesterday that had something. I always hate to tell this word, but it's called in the literature double crush, where they had a pinched nerve in the neck and also a pinched nerve in the wrist. So there's often that scenario where people can get really horrible numbness because they happen to have two places where the nerve is pinched. The other thing it can do is if there's nerve damage, in many cases, it can be picked up too. So it can tell you kind of the severity if it's just a pinched nerve in the neck. Again, not always. So but it's often a clinical question: is this nerve damaged, or how bad is it? And the EMG may be useful in helping that situation. That's a good question, and one that's often happens from our treating doctors at Rothman. They'll send them to me for that reason.
Thank you. I think we have a couple more minutes for a couple more questions. Um, this person, oh, I have this question about acupuncture. What are your thoughts on acupuncture? Is it helpful for stimulating nerve regeneration?
So interestingly, in most cases, if you go to a licensed acupuncturist, there is very little very little reason, contraindications, we call it, to not see them. The times where you can't do it, if someone had lymph nodes taken out, like breast cancer, and they had to have take the lymph nodes out, those patients will be told you can't have needles or blood pressures taken in that arm, or if someone had, with a skin infection, or those type of things are times where you can't have it. As far as nerve regeneration, acupuncture is sort of a black box thing that it's been around for a long time. It's used routinely in Asia, and a lot of patients will swear by it. So in the United States, we have a different sort of it's not covered by many insurances, so that's sometimes a barrier. But in terms of does it help, it's all over the map. What we think probably for those people that it does help is that it probably improves the blood flow to whichever areas that it's being done in. and which may aid in what's called oxygenating the tissue or possibly helping with healing. Um, we don't have enough data to say that it does routinely. And I, certainly wouldn't tell someone that they couldn't try it. My feeling is it's a relatively safe thing to do. If it helps, great. If it doesn't, it's unlikely to cause any harm. But we don't have great data on just how much it helps. And there's really not a good way to tell if it will help. The general wisdom from colleagues that I've had who do acupuncture and from what I've read on it too, is that you usually need to go about 3 times to know if you're getting any benefit from it for most conditions. It is unlikely to harm you and may help. That's my best answer. We don't have great data.
Thank you. Um, Couple questions about people who have dropped feet. Can they be tested and simulated?
Yes. So absolutely. So that's actually one of the main reasons we get people is if someone has a drop foot. Um, so number one, especially if it's relatively recent, because you want to know, one, how bad is it? Two, is it potentially reversible? Depending on where it is. So the nerve can get affected that pulls your foot up, and it could be affected from bad nerve compression, like from the nerve being pinched in the back, specific nerves. It can also be occasionally from one that goes around the lower part of your leg, or sometimes as a complication of a hip dislocation, like or someone fell or broke their hip. So there's things that can cause it. If it's been going on for many years, then probably number one, we can certainly still test it. What you may do with that information, if it's never been diagnosed, then oftentimes people will want to, treating doctors will want to know, and a patient will know what's causing it. But you absolutely can get tested, and typically at some point along the way, unless it was from something like a stroke. And a stroke is usually pretty straightforward. It happened when I had the stroke, as well as, maybe some other symptoms. But it's one of those things that absolutely is appropriate and our doctors too will often order that to kind of see what they're up against.
Right. Thank you, Dr. Simon. I think we're getting to our hour mark, so thank you so much for answering all those questions. Thank you for your informative presentation. Thank you everyone for joining. If we did not get to your question, we apologize. There were a lot that came in, but thank you again for joining us this afternoon. And like I mentioned, we did record this. We will be sending it out to view. We'll likely send it out early next week. So you will all receive it. You do all have my email address. If you have any questions, concerns, need to schedule an appointment or an EMG, please feel free to reach out to me and I'm happy to help facilitate that. So
Thank you,
thanks again, Dr.
Natalie.
Simon.
Yep,
Thank
thank you,
you.
Natalie. Yep,
Yeah,
thank you everybody for coming, and
yes.
we're happy to have you.
Have a great day and have a great weekend.
You guys too.